This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1194, recorded on February 20th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
With a really colorful bow tie.
This is, so this is Yersinia pestis. This is the plague, which seems very appropriate for what's been going on recently, Vincent.
Yeah, we're in a plague. We actually have some plague things. We have measles in Texas. We have tuberculosis in Kansas. This shouldn't be happening.
It really shouldn't. So I thought this quotation that I put up front from Charles Schulz, right? Peanuts, Charlie Brown, all the rest. And maybe this is something our listeners, we probably have kind of a skewed listenership. And so probably a lot of our listeners are kind of overwhelmed with what's going on right now. So from Charles Schulz, I have a new philosophy. I'm only going to dread one day at a time.
That's not a bad idea, Daniel.
Well, I don't want our listeners to be overwhelmed, right? We're going to be talking about the science. We're going to be keeping people informed as long as we're able to keep doing that. And I there's a little bit of optimism. So I just was shared with me recently an article on Dickson des Pommiers that was in the New York Times, and I'll leave in a link to this. And some of our listeners probably know Dickson from the deep dive, right? This Week in Virology. Wasn't he, I think you and Dickson started this all off, right?
Yeah, Dickson and I started TWiV, yeah. When I was looking for someone to be a co-host, I went to Dickson because I knew he was a good raconteur and teacher, and that was back in 2009, I think. And and he's been with us ever since.
Wow. Yeah, and I was looking back. I joined with you and Dickson on This Week in Parasitism more than a decade ago. So, yeah.
And then you were there when COVID started. Then we said, let's do a weekly update, right?
Yeah.
And here we are still doing this weekly update.
Crazy, and we haven't missed a week, which is just, sort of craziness.
Just folks, this is because we want to tell you what's going on. We want to teach you. That's what it's all about. Unselfish teaching you.
Yep, I'm still waiting for my check. No, I mean, and maybe people don't know this, but yeah, I mean, there's no fee. I don't get paid. This is pure. I do this because I'm hoping to make the world a better place. I'm hoping to share information, and so along those lines, in this article in the New York Times, there are Dickson's two questions. And Dickson and I spent a lot of time together. We drove down to American Society of Tropical Medicine and Hygiene meetings. We hung out quite a bit. And he really was, I think, a raconteur. That's what I think that, yeah, he had stories. He was inspiring. And one of the things he asked in his class, and they capture that in this article, is he starts off by asking the class, this medical ecology class, what will the world be like in 2050, right? And then everyone kind of talks about all their different ideas. And this is really the best follow-up question. He says to the class, he puts it as a challenge to the class, and I'm going to put this as a challenge to everyone that is listening to this. What would you like the world to be like in 2050?
That's great.
Right? Because the future's up to us. So, yeah.
So the thing about Dickson, Daniel, is that whenever he was on a podcast, that it wasn't going to be boring. It wasn't going to have any dead space because he liked to talk, right? And when you asked him questions, he would love it. And all you had to do was ask him questions. Sometimes he'd be quiet, and I would say, Dickson, how many viral genome types are there?
Yeah, and he would go through all the Baltimore classifications. He
Well,
wasn't a trained virologist, but by, 15 years of TWiV, he certainly was.
yeah, for sure. So I
Yeah,
enjoyed very much when he was on our programs because he was always fun. He always had jokes to tell, stories. I'll miss that a lot. Yeah.
yeah, I definitely will. And particularly, we could use Dixon to still be around. As you and I were talking a little bit earlier today, these are tough times. It seems like I feel like we're back in the early days of the pandemic when suddenly, getting like death threats. Dr. Griffin, you're giving vaccines and you're withholding hydroxychloroquine, ivermectin, you're killing millions. And, these cease and desist letters from lawyers. And it's kind of tough to see. But we're going to keep doing this.
Yeah, we're going to keep doing it. Yep.
All right, so let's jump in. And Ebola, we might have a win here in Uganda. I was unable to access the WHO page, but I have heard and had this confirmed from people on the ground in Uganda, and actually from people that can access WHO information from outside of our country, that Uganda has discharged 8 patients who had been receiving treatment for Sudan virus disease, right? So this is a type of Ebola. After 2 negative tests carried out 72 hours apart. We hear this from the WHO. People on the ground in Uganda have confirmed this. And remember, there were 9 individuals. 1 died. 8 of them are now cleared, recovered. And the recovered patients were receiving care mostly in Kampala, but actually one was out there in Mbale. So that's the town in the east of Jinja, not far from the FIMRIC clinic where I go. There are a total of 216 contacts currently being monitored in quarantine centers, various facilities in the country. And maybe we'll leave put this up on YouTube. But when I try to go to the WHO Uganda, I get access denied. You are not authorized to access this page. So what's that about? Okay, let's move on to polio. Vincent, a way to always keep you from being quiet. Polio.
Indeed.
WHO Executive Board says emergency measures needed to stop polio. Global polio and health experts urge right geopolitical decisions to stop perfect storm for polio virus transmission and protect eradication. Do they mean something like using IPV?
Well, it's more likely that this means running vaccination campaigns, either routine or supplemental, without political interference, while retaining the same philosophy that OPV is the vaccine of choice because it stops transmission, which it doesn't. So the perfect storm, I think, is political instability.
Yeah, I mean, I think that's where they're talking about this article, right? They're talking about Pakistan, they're talking about Afghanistan, and they're really talking about this issue with political instability. So what do we read here? We read that the year 2024 saw an increase in virus transmission in both of these countries, Pakistan, Afghanistan, which share the last remaining endemic wild poliovirus reservoir in the world. WHO member states commended the new emergency operational approaches being now implemented in both countries to turn the tide of this trend. These approaches include identifying the different operational reasons why the children are not being reached area by area, increasing co-administration, right, of IPV alongside OPV, boosting overall immunity levels in children and improving access to more adequate sanitation infrastructures. So I wanted to talk a little bit about this, Vincent, because they're making a big point here about this is wild polio virus. But when a kid gets paralyzed, right, I don't really see the difference if the kid is paralyzed by wild polio or they're paralyzed by a polio virus that's now in the wild, but originally came from a vaccine.
Yeah, absolutely right. There's no difference. They both causing paralysis. And in fact, there's far more vaccine-derived polio than wild polio causing paralysis. And that's our fault because we keep using OPV, and that's what will happen if we keep using it. But yes, you're absolutely right. It's poliovirus. It's causing paralysis. There's no need to distinguish. So people say, oh, we've almost eradicated polio. They're talking about wild polio. But no, in fact, you haven't because there's so much poliovirus out there causing disease.
Yeah. And then we hear right away that WHO says polio mass vaccination campaigns to resume in Gaza. We read about this in Reuters, and they've got a picture of this little Palestinian child receiving oral polio virus, which will end up in the environment, which will put others at risk. So,
Well, this is not the right thing to do. We should be using IPV because all this does is add more OPV to the environment. It circulates and it finds people who are not immunized and causes paralysis. We really need to switch to IPV, but the people in charge at WHO are not thinking that way.
yeah. So if the U.S. takes over Gaza, does that mean that they're not allowed to use OPV and they have to go to IPV? Do you know about this, Vincent?
I know it's a good question, but we're very fortunate that we use IPV, right? We've delicensed OPV. That's the right thing to do. But it's not clear that, we allow OPV to be used in other countries, and we shouldn't be. Right?
Yeah. I mean, the argument is difficult when you look at Afghanistan and Pakistan, where they're doing both. When I was in Zanzibar, they're doing both. Like, if you've got IPV, why are you there with OPV? I'm not sure I understand.
You just need one, and it should be IPV. We've been saying this for years now.
So we'll keep saying it. We'll keep saying it. All right, measles, ouch. The measles outbreak in rural West Texas has grown to, well, as of Tuesday, 58 cases. There's updates like every Tuesday and Friday, so people can keep following this. But it's also spread to neighboring New Mexico. There's at least 8 people over there. Some people are estimating we're already up to 200 or 300. We're just sort of not keeping up. But yeah, this is the largest measles outbreak in decades. What would be what would be the tools to approach this? Let's just be honest. What's the evidence? You don't have to use that word science but what's the evidence? The evidence is that we have a vaccine, a very effective vaccine, and that vaccine will keep these kids safe. I mean, 1 in 5 kids are going to end up in the hospital. Actually, it's been higher. It's been 40% in recent years, ending up in the hospital. And you may not die of measles, but some of these kids are permanently deaf. Some of these kids have encephalitis, damage to their brain. So yeah, it's not just, do you die or not? It might be a small child ending up in the hospital. It might be a small child ending up with permanent damage. So
I heard that, overall in Texas, the measles immunization rate is over 97%, which is great. But this outbreak is in a community with about a 30% uptake of vaccine due to medical exemptions. 40% medical exemptions. Isn't that ridiculous? Well, it's not the right number, but you get the point. That's why there are cases all in this little area, because people are all immunized and they're spreading viruses among them. What are the parents thinking, Daniel?
Yeah, I mean, unfortunately, this is an area where there's a large number of unvaccinated protected children. I think we talked in previous episodes about 300,000 unprotected little kids, kindergartners and younger in the U.S. And so, this is horrible. And we didn't want to get to the point where you have to see this for people to realize, oh my gosh, measles actually is really bad. So it's sort of a call out to the mainstream media. I mean, maybe people need to see little kids in the hospital to appreciate, just the impact here. All right. We got a lot on avian or bird flu. Here it is, cats and bird flu. We've been waiting for this, Vincent, and we have the MMWR, highly pathogenic avian influenza, influenza A H5N1 virus infection of indoor domestic cats within dairy industry worker households, Michigan, May 2024. So this is a great story, right? So, we're talking about Dickson before telling a story, and some of these MMWRs, really, it's a story. So let's go through the story. So what's going on here? So May of 2024, hey, that was like months ago. What's going on? Why are we only hearing now? But May 2024, the detection of highly pathogenic avian influenza A, H5N1, virus infection in 2 cats, that were reported to be exclusively indoor and that had respiratory and neurological illness in different households, prompted an investigation, right? So we've got Michigan Department of Health, Human Services, and the Mid-Michigan District Health Department are going in, the detectives here. The cat's owners and household members were interviewed and offered testing for influenza, the H5 virus, right? So of course they're all going to say yes, but let's find out what happened. Well, the owner of one cat worked on a dairy farm and declined testing. We'll get into why people don't want to get tested. 3 other household members did get tested and were negative. The owner of the other cat, because we're going to go through each story individually, the owner of the other cat lived alone and worked on multiple dairy farms transporting unpasteurized milk. This reporter also reported getting splashed in the face and eyes by unpasteurized milk, but he also declined testing. Both workers were employed in a county known to have highly pathogenic avian influenza A H5N1 virus. And here we're going to get in. This is, you don't have to remember this, but it's sort of mix and match recognition here. So this is H5N1, clade 2344B, genotype B313, right? So for those of you that were around for our primer on flu, right, we classify them based on the H and the N, a bunch of different numbers. The higher H's tend to be the avian and other species, so H5N1. But then you can actually go farther. The next step of classification is clades, and then the genotypes. And remember, the genotype B was the first into the bovine, and we talked last week about the D also now getting into cows out west. So we'll circle back to that. So let's go through Cat 1, because there's going to be the Cat 1 A and B, and then there's going to be Cat 2's A, B, and C. So Cat 1A, that's the index cat, aged 5 years old, exclusively indoors, doesn't go out, spayed, female, domestic short-hair cat, experienced decreased appetite, lack of grooming, disorientation, and lethargy, followed by progressive neurological deterioration. The next day, on the second day of illness, the cat was evaluated at a local vet clinic. On the 4th day, the cat ends up referred to Michigan State University Veterinary Medical Center. This is actually a tertiary care facility. They've got advanced capabilities. And the cat is getting sick so quickly, they end up euthanizing the cat. But because of this exposure concern, they end up getting approval. The cat's remains are submitted to the veterinary diagnostic lab. Brain and nasal swabs are tested by PCR. They all end up positive for the influenza H5 virus. And which one? It's the clade 2344B, genotype B3.13, right? So the one that we're familiar with that got into the bovine. Now, Cat 1A lived in a household with 2 adults, one of whom worked on a dairy farm in a county known to have the H5N1 positive dairy cattle, known to be that clade B that we're talking about. 2 adolescents and 2 other exclusively indoor cats. We've got a Cat 1B and a Cat 1C. Cat 1B was reported to have signs of watery, purulent eye discharge, increased respirations, decreased appetite, basically gets sick about 4 days after onset of illness in Cat 1A, the one that's already died. They request the owner obtain a swab from Cat 1B because the cat was too ill to be taken to the clinic, but the owner doesn't send in those samples. But fortunately for cat lovers here, Cat 1B's illness did resolve 11 days after Cat 1A's illness onset. Cat 1C had no signs of illness and negative testing. Okay. Now, that's our first sort of cluster of cats. Now, 6 days after referral of the Cat 1A, Cat 2A, so now we're in household 2. Cat 2A.
Wait, is this a Dr. Seuss story?
It sounds like a Dr. Seuss story, right? I got to follow this on. So you got the first house with Cat 1A, B, and C. Now you've got a second household, and this is going to be with this. They're going to be a 2A and a 2B. And 2A is an exclusively indoor, intact male Maine Coon cat. Have you ever seen a Maine Coon cat, Vincent?
I have, yeah.
They're huge, right?
Big. Yeah, very fuzzy too.
It's all fur. It's all fur. Don't be intimidated. It's all fur. So they've got this huge Maine Coon cat. It's 6 months of age. It's already pretty big by then. And he gets brought in by the owner directly to, the MSU vet place. And he, for about one day, he's been sick, but he's already had neurological deterioration. He's got anorexia. He's got facial swelling. This cat 2A, the Maine Coon cat, was obtunded, cranial nerve function issues, abnormal motor function. The cat ends up dying within 24 hours of getting sick. Okay. Now, cat 2A, the big Maine Coon cat who just died, lives with a second cat, cat 2B. And this is the one guy, he's living by himself with his two cats. He is a dairy farm worker. So they test, they do nasal swabs from 2A. They do the reverse transcriptase PCR at this MSU VDL, and they end up positive for H5N1. And again, clade 2344B and genotype B3.13. Right, so it's the bovine attenuated, well, not attenuated for cats. Mm-hmm. Cat 2B doesn't show any signs of illness. He gets some negative testing. So now they start talking to cat 2A and B's, cat 2's grouping owner, because he actually starts to get some symptoms. He gets some eye symptoms, some eye irritation. Now, here's the weirdness, right? His symptoms start 2 days before the onset of illness signs in cat 2A. The owner does not receive testing, declines any treatment, actually declines further contact with public health officials. He states he's afraid of cooperating with public health because he is concerned he will lose his employment as a consequence of communicating with public health and potentially implicating the farms, that provide the milk. Isn't that kind of crazy times?
Totally. Yeah. So, I mean, the guy could die. Who knows? I mean, he's not going to because this is the bovine. But, you take this risk that you'd rather not get testing and treatment. It's crazy.
It's tough times, right? There should be protection. There should be, listen, if you're sick, you should be able to get tested. You should be able to get care. You shouldn't worry that, somehow there'll be a witch hunt. You're going to lose your job.
Well, as you know, you have to agree to testing and treatment, right, Daniel? So,
yeah.
The problem is that he's worried and he needs assurance, right? But which he can't.
Yeah, he would need some kind of, some sort of assurance, some sort of protection that, hey, if you do the right thing and you get tested and you, and I think a lot of these, we're up to, we're going to talk about this. We're up to almost 1,000 dairy herds that have documented avian flu in these dairy herds. Yeah. And, somehow they need to know like they're going to be okay. And so, unfortunately, along these lines, Arizona officials announced, it was really like right after we recorded last week, that they have identified H5N1 in milk produced by a dairy herd in Maricopa County. And this is a second spillover of the D genotype, right? So we got the D genotype up in Nevada and now Arizona. The original B genotype spilled probably in like Oklahoma or Texas area. It's now spread to hundreds and hundreds. We're up to almost 1,000 dairy herds. So this is the third spillover. So one spillover of B early on. Now we've had 2 genotype D spillovers documented just recently. So what to do? The U.S. conditionally approves a vaccine to protect poultry from avian flu. All right. And so there is a vaccine made by Zoetis, Zoetis, Zoetis. And this contains a killed version of H5N2 that the company has designed to work against circulating variants of the H5N1 virus, right? So you're going to get a probably good match at the H5 there. And we read that the decision to vaccinate commercial poultry flocks rests solely with national regulatory authorities in consultation with their local poultry sector. Zoetis also had an earlier version approved in 2016 that was in the National Veterinary Stockpile until 2021, but it was never used. So I thought I'd give people kind of a refresher about like, what's this story? People probably don't remember. That was 9 years ago, right? No one remembers 9 years ago. So back in 2016, right? Who was president back then? Do you remember? That was Barack Obama, right?
Yeah, it was Obama, sure.
Yeah. So under Obama, the U.S. government had a contract that called for 34.2 million doses of avian influenza vaccine, H5N1 subtype, and killed virus, with a little asterisk there, valued at 3.42 million to be delivered in 2016, and then another 34.2 million doses valued at another 3.4. So we're talking about $6.84 million worth of vaccines that the U.S. government pays for. So the USDA granted Zoetis back then a conditional license for that vaccine, intended for use in chickens as an aid in prevention of disease. Then it just sits there in the stockpile, never gets used. So I sort of suggest people don't remember this, but under President Obama, there was an outbreak of highly pathogenic avian influenza during the spring and summer of 2015, with the largest animal health emergency in the country's history, according to USDA. More than 49 million birds died. And this is back when they detected this in migratory birds and barnyard flock in 21 states and commercial flocks. So I thought this was a good time, Vincent, to talk about vaccinating chickens, because I know our Canadian co-host was not a big fan of vaccinating chickens. So, sort of talking about logistics. So I'm going to leave in a fun WikiHow link, 4 ways to vaccinate your chickens, plus prepping and cleaning up. So we do vaccinate chickens. I don't know if people know that.
For sure.
So we vaccinate chickens, and there's a bunch of different vaccines, right? So we've got an E. coli vaccine that we give to 1-day-olds. We've got a Marek's disease. Maybe that's been talked about on TWiV, given at a day old to 3 weeks. And that's actually sub-Q. That's injected like this vaccine would be. There's an infectious bursal disease vaccine given at 10 to 28 years old, and they put it in the water. They put it in the water, and then just all the chickens come and drink. There's an infectious bronchitis vaccine. They give this 16 to 20 weeks. So think about that, right? We talked about usually the broilers are have been eaten by then. So it's probably going to be more of a hen vaccine. And you go around, either you put eye drops in or you spray it, get it in their eyes. There's a Newcastle disease. Again, you put in the water eye drops. There's a fowlpox vaccine. And there's even a laryngotracheitis vaccine. So I'm going to leave in a whole bunch. And there's even some of the vaccines you actually put in the eggs in ovo. So even before any chicks hatch, you actually can put it on the eggs. And
So one of the things that Angela said is that vaccinating flocks against bird flu has an impact on export of birds, because most U.S. trading partners won't accept exports from countries that allow vaccination, because they think the vaccine can mask the presence of the virus. So, this vaccine being approved, that's great, but they're not going to be able to export them.
It's kind of an interesting, question, right? So the way the current dynamic is, right, and it makes a certain amount of sense, right? Because we talked before, like, these dairy, people own these dairy herds, they don't want to find out because what's going to happen.
Yeah.
And so now if you find out that your poultry operation has H5N1, they have you kill, it might be 2 or 3 million birds. You just kill them all.
Yep.
But then you get compensated. Right. So there's a way to say it's going to be okay. We're going to give you money. You're going to replace what was lost. This is like when the wolves take down, animals out west.
Well, Daniel, don't be sure that Mr. Musk is going to block the compensation.
That's a concern, right? I think now, uncertain times, people may be wondering, like, I don't know, that's what's been happening so far, but is that going to keep happening? If I kill my 3 million chickens, my 3 million hens, is that check going to really come in the mail? I don't. Yeah. So a lot of concerns there, and it's interesting in the discussions I've heard so far about how we're going to tackle this. The word vaccine has not come up, and maybe I'll just sort of stop there. Something about like chickens don't fly. Why are we killing chickens? But anyway, all right. Last Friday, right after we recorded, the 3rd person in the U.S. was hospitalized with avian flu, and this person's from Wyoming, and they ended up getting hospitalized down in Colorado. And then Ohio confirmed Saturday, we've got a 4th guy who was sickened by bird flu and ended up hospitalized with H5N1. So that's 4 so far. And yeah, what about vaccinating those hens or people? Well, I thought this was really curious, right? Because it was Dr. How do we pronounce her name? Mangarello?
Mingarelli.
See, that's perfect. I'm going to let you go with that because it's got that nice Italian flair. I just would botch it. So, she's Canadian, and the Canadians might be one step ahead of us here because the Public Health Agency of Canada announced that it secured 500,000, 500,000 doses of GSK's human vaccine against avian influenza. And this is an H5N1 vaccine that uses established technology for seasonal and pandemic flu vaccines. And Health Canada had actually completed a review of GSK's regulatory submission for this. So maybe if we want our avian flu vaccines, we got to go visit Canada.
No, I think you have to be at risk also,
Yeah.
Daniel.
I think this will end up in a stockpile, money, money spent on a stockpile. Yeah. And I don't think it will make sense when you start looking around of vaccinating everyone. So, all right. What about human influenza A, if we can call it that? Influenza A activity continues to be very high throughout the country. Looking all about the country, we're a little bit behind, right? The last update that I have for us to look at as far as the heat maps here is February 8th. And I actually looked for updates, right? So, it's basically we've got flu activity really high across most of the country. And there's a page I go to, right, for these, weekly updates, to see how are we doing? And we talked last time about pediatric deaths. There have been 10 the week before, a total of 57 deaths this season. That page hasn't been updated since February 7th. So, I think it's important. My parents were just telling me today that one of their friends died, and my parents are older than I am, and their friend was even older than they are, and they're going to be going to a funeral. So, sort of asking me about do we have to worry? Is there a lot of flu going on? A lot of other stuff going on? I mean, I think people rely on this data to make decisions about how to stay safe. So. All right, RSV, it also continues to be very high. So flu is high, RSV is high, norovirus is high, and COVID is still very high. So the four horsemen of the apocalypse are upon us. Looking around the country, we're still seeing that we're about 1,000 a week are dying. We're a little under 1,000 a week that are dying from COVID. We're a little over 1,000 a week are dying from flu at the moment. So flu, for the first time in a while, has got a little bit eked ahead. But I was talking to one of the USA News, I think it is, USA Today, one of those reporters about this issue that, COVID has a much broader period of time when it's killing 1,000 people a week. So flu tends to have this narrower peak. So at the end of the day, COVID is still winning year out in number of deaths here in the U.S. Looking at wastewater data, we didn't really come off that peak. We came down and we're sort of sitting on this plateau. So still seeing lots of COVID cases. All right, and we've got some new science, interesting. And this is I'm going to be heading to Malaysia and Thailand in about a week from Monday. And so I'm going to put this in one of the talks that I'm doing over there. And this is this article, COVID-19 case fatality rate and infection fatality rate from 2020 to 2023, nationwide analysis in Austria, published in Journal of Infection and Public Health. So this is a retrospective observational study, included all Austrian residents and covered the time from February 2020 to May 2023. All right, so they're examining CFRs, case fatality rates overall, monthly, and during dominant SARS-CoV-2 variant periods. And the case fatality rates were calculated for the whole population, and then they're going to stratify them for various features. They also have IFRs, infection fatality rates. Those are a little harder to get, right? Because you've got to try to estimate how many infections, because some of those are going to be undocumented. All right, so the overall end of the day case fatality rate, 30-day COVID-19 mortality, 0.3%, but it really varied widely depending on the month. So the highest, early days, remember when we were at 5.9% in April 2020, and then we got to the lowest 0.07 in January 2022. We're going to talk a little bit like, wait, that was a few years back. Why was it lowest then? Are we higher now? But the variant periods reflected this trend of decreasing case fatality rate. And if you kind of break that down for everyone, you have this elevated level for the Wuhan HU1, and then it is lower for the BA1, right? One of the Omicrons. The overall case fatality rates were particularly high in folks that had not had a previous immunizing event, the elderly, and then really high in nursing home residents. And nursing home residents accounted for about a third of all COVID-19 deaths, while they only represented about 1% of infections. And then they've got these really, really nice figures. So I'm going to put my glasses on to look closely at these figures. So, and I'm going to leave in a link. I'm going to recommend people take a look through this. But it's really critical when you look through, and some of the stuff actually you have to go to the supplemental data. You click on it, it's a Word file, because you really want to, when you're looking at impact of vaccination, you want to make sure you match, right? Because we're going to do a much better job of vaccinating the elderly than the young people. So you don't want to say, oh boy, look, the young people, they weren't vaccinated and they did fine. And the old people, you really have to ask, if you're over a certain age, how did you do? So I tried to break this down. I'm going to walk everyone through this. I walk through the supplemental figures, Vincent. I don't quite understand what ends up as a supplemental or not, but they break down the supplemental figures. And then I really zoomed in on we'll start off with the over 85. And actually, it's pretty interesting, right? I talked about how we sort of had a low in early 2022. And actually, the case fatality rate went up, right? There was sort of this idea, oh, now it's Omicron. But actually, you saw this actually go up, and a clear difference between no immunization, higher mortality than clearly than hybrid or previous vaccination. But really interested, just pure documented previous infections, they actually started to come up. These documented infections seem to not be giving this, this survivor protection that we were thinking about. And then if you move into the 75 to 84, kind of interesting, again, we're starting to see a rise in the mortality in the never immunized folks, and also a rise in the previous documented infections. So basically seeing this durability of protection to prior vaccines. And so, I'll recommend everyone look through this. Even you go to age 60 to 74, we're actually starting to see a rise again, up to a couple percent mortality in age 60 to 74 in folks that never got those vaccines.
Interesting that nursing home residents, 30% of all deaths, but only 1.2% of infections. So you see they're extremely vulnerable.
They really are. And it reminds me of two things. One is, Peter Hotez was his early quotation before Congress. COVID-19 will be the angel of death in the nursing homes. And he was right. Yeah. And I think the other, which really, that was something that people may not remember, but in New York that Cuomo got a little bit of backlash for it. Basically, they were hiding the nursing home deaths because it was going to make us look bad, right? And everyone talked about how transparent he was. And it came out like, 6 months in, hey, how come you're not counting those? Oh, we don't want to count those. And there was a song and dance. But yeah. All right.
What Mark Twain said, if you don't lie, you don't have to remember anything.
That's the problem when you start lying, is that you got to remember your lies.
Yeah.
So, all right, COVID early viral phase. So here is a study here. And this article, a randomized double-blind phase 1 single and multiple dose placebo-controlled study of the safety and pharmacokinetics of IN006, an inhaled antibody treatment for COVID-19 in healthy volunteers, published in eBiomedicine. Just think of it This is, you're going to inhale antibodies and you're going to see if it can knock down that virus. It's phase 1. So later on, we'll find out if it actually helps anybody. But yeah, they actually go ahead and they have 23 participants. They enroll them, they randomize them across 2 single dose and 1 multiple dose cohorts. And they're going to get 30 milligrams or 90 milligrams of these nebulized doses, or 7 daily 90 milligram doses. And everyone does fine. No serious adverse events. The nebulization was well tolerated. It takes like 6 minutes to do this. And then they're going to look at the geometric mean nasal fluid concentrations in the multiple dose cohort. We get some numbers down there and some doses in the others. But you get these really high levels, and they're going to say, hey, are these levels high enough? And we don't know. We really don't know, pending efficacy studies. They do say, hey, these concentrations, the respiratory tract, are orders of magnitude above the IC50 range that is typical of antiviral monoclonal antibodies. But we don't know if that's really the site of action, right?
Also, Daniel, the levels of antibody go from 740 micrograms per mil 30 minutes after dosing. A day later, 1.2 micrograms. Oh my God, in 2 days, you're not going to have anything left.
And then it's like half a microgram per ml 3 days after this. So it really drops super quickly. Is that enough?
Yeah, I mean, if you want to be protected for 1 day, but that's not really reasonable.
Yeah. So I don't know. I mean, I think it's really interesting, right? There are people that don't like needles, they don't like infusions. And I love people that have options, right? Because, early in the pandemic, we had this issue where for certain reasons, there were people that they did not want to get an active vaccine, but they were good with the passive vaccine, right? And so there were these pop-up monoclonal clinics all through much of the country, a lot of them down in Florida. We did a lot setting these up because there's certain people that they didn't want to get a vaccine, but they, once they get a positive test, then things change and they'll come in and get a monoclonal. Maybe they want to take a medicine. Maybe they don't want to take a medicine, but a monoclonal was viewed somehow different. Yeah. All right. We also have the article, a little disappointing article. Ensitrelvir for the treatment of non-hospitalized adults with COVID-19 results from the Scorpio HR phase 3 randomized double-blind placebo-controlled trial published in CID. Basically, they're going to try ensitrelvir. They're going to see if people get better quickly, more quickly. They've got this really nice, I love when they have these graphical abstracts where they put everything together. Basically, people, it wasn't significant. There were maybe some subtle changes here, maybe like a few hours, maybe quote unquote, because there was overlap here. So we're just not sure. We do have evidence, right, as we've talked about, that things like Paxlovid and remdesivir and molnupiravir can decrease progression to hospitalization. They can decrease your chance of dying. But here in the Scorpio trial, where they're just looking at, do people feel better more quickly, we really weren't seeing much of an impact.
What is ensitrelvir?
So this is a once a day antiviral that they use over in Asia.
What's the target? Do we know?
Actually, we know. Do I remember? Let's take a look, Vincent, in real time. Let's look up so we know. Ensitrelvir.
Protease inhibitor.
Yep.
Okay.
By Shionogi. And it's still, I believe it still has the same drug-drug interactions, but I think it's like five days of once a day, so it's more convenient dosing. So it's got some potential. Well, could have had some potential benefits if it actually really works. So what are we left with? And we are left with number one, Paxlovid, right? That's about an 80-90% reduction in progression of whatever your baseline risk is. And we've talked about the fact that folks are not keeping up with their vaccines. People are relying on, prior immunity, but we're starting to see a 1 or 2% case fatality rate in folks above 60. So, be nice to drop that even lower. Nice to not see 900 people dying a week. Here in the US alone, we have remdesivir, the challenge of that being IV. We have molnupiravir as a third option. And in some context, there still might be a role of convalescent plasma. And then second week, I like to remind people that can often be the bad week. This is what we're targeting. We don't have a lot of great data that we can make you feel better more quickly during that first week, but we can not minimize the risk of having a bad second week, but we can minimize the, dare I say, badness of that second week. We can minimize, how likely it is during that second week that you'll end up in the hospital, how likely it is during that second week that you'll progress and end up not surviving the infection. And if you do progress, and we have some of these folks in the hospital, steroids, anticoagulation, pulmonary support, maybe still a role of remdesivir, and in some cases, immune modulation. And unfortunately, we still have, I think the estimates are now about 1 to 2% of folks going on progressing to late phase PASC or long COVID. I'll leave in some links to some information. But yeah, that continues to be a challenge because a lot of folks say, hey, I'm under this age. I'm not at risk of ending up in the hospital. I don't think I'm going to die. But oh my gosh, I don't want to, lose my life and be debilitated with all the post-COVID issues. All right. And so as we've been saying for now 5 years, no one is safe until everyone is safe. I'd like everyone to pause the recording here. And go to parasiteswithoutborders.com and click donate. We talked about this early on. We are really losing a lot of sources of information. The environment is getting pretty hostile to people that are trying to keep others informed with reliable information, with folks trying to share with you the information you need to be safe. And we need your support. We don't do any ads. This is all, your support. And right now, not only are we supporting the science communication that we're doing, but we're having our Floating Doctors fundraiser where February, March, and April, we're hoping to double your donations to get up to a maximum donation of $20,000 to help our folks down in Panama. And things are pretty dire down there.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Jessica writes, I'm currently 5 weeks pregnant, expecting in October. I got my flu shot and Novavax booster last November. Since it's been a few months, should I get an extra flu or COVID vaccine now that I'm pregnant? As I understand, I should also get these vaccines during the third trimester to protect the baby during their first 6 months of life. So what's the best timing to optimize protection for both me and the baby during and after pregnancy?
Yeah. So Jessica, thanks for writing in. I think you wrote in before about some hand sanitizer, which we'll talk about. But so what's the data? What do we know here? What are the studies? So, one is pregnancy is a high risk situation. You're about 18 to 20 times more likely to have an issue during pregnancy. So again, whatever that baseline risk is, I remember, early in the pandemic being asked about this, in general, but it's in general, people who are pregnant tend to be younger. They tend to be healthier than sort of your average American. But that's not true of everyone who's pregnant. Some people who are pregnant may be carrying extra weight. They may have medical problems. So whatever your baseline risk, you did the right thing. So the vaccines is evidence-based, going to reduce your risk. But then we also have looked at studies where now the recommendation is third trimester vaccination. And it's really the beginning of that third trimester. It looks like that's going to give the most optimum protection to the newborn.
And Jessica says, P.S. regarding my question a couple of weeks ago about benzalkonium chloride hand sanitizer, there exist commercial hand sanitizers and wipes sold by companies like Baby Ganix that claim to be gentle on the skin and even safe for use on babies and children.
Baby Ganix, that's like a little spin. It almost sounds like it's organic, but they don't say that in there. But it suggests that to my mind. So it just sounds from the name like to be a wonderful product.
Carmen sends a link to a Cornell Veterinary College webpage which is basically a bird flu resource center, and she says thought this looked useful. So maybe put that in your collection of things to replace other websites which are becoming less useful.
This is actually a good page for listeners. I endorse the vet.cornell.edu, and they've got different sites, and it's the highly pathogenic Avian Influenza Bird Flu Resource Center. Lots of great pictures. You go down all kinds of different rabbit holes there.
Ginger writes, my 80-year-old friend had a prescription of Paxlovid on hand when he tested positive for COVID. He initiated treatment, then informed his doc. He got chewed out, as she stated she would not necessarily have prescribed it for him. When questioned, she sent this response. Thanks for your message. It's not that I don't write for it, but I don't routinely have people start it just with a positive COVID test. Certainly, if the symptoms are severe, then we start it, but I'm not as keen to start if the symptoms are mild and you are recovering well on your own. Often, if people take Paxlovid with mild symptoms, they end up feeling worse from the side effects of Paxlovid. I'm still providing it for international travel, but review those caveats with patients. Also, we do not have enough evidence that using Paxlovid prevents long COVID symptoms. So that's the new data that's influenced my practice. Last year, we didn't have any data, but now we have enough to show it doesn't benefit or prevent long COVID. Thoughts?
I mean, there's several aspects to this. So, I remember when I trained last century, the idea back then was that if someone had pneumonia, they had to take antibiotics for 21 days. And then, the doctors would berate the patient. Why didn't you finish the antibiotics? It's 21 days. And they would tell them, song and dance about, how terrible a person they were for not finishing their antibiotics. And I sort of joke that now that we know 5 days is actually appropriate and going beyond that actually starts to get into the realm of harm. These doctors have a list of all those patients and they call them back and humbly apologize for all that opprobrium. And, we were wrong, right? I mean, and unfortunately in this situation, you've got an 80-year-old who tests positive for COVID. If they have symptoms, right? So they test positive for SARS-CoV-2. If you're 80 years old and you have symptomatic COVID, you don't wait to see how they're going to do. You don't see like if they get worse. The most benefit, that 90% reduction, is if you start within 24 hours of that positive test. So this is one, counter to the evidence we have. Two, it's counter to the recommendations of our professional societies. It's counter to our guidelines. So, boy, why would this doctor berate the patient? That's just not right. We need a little more kindness.
Do some doctors not pay attention to the professional society recommendations?
It makes me kind of wonder where they're getting their information, and I worry that it's from the media and not from the journals.
Gosh, it's unacceptable. All right, Lisa writes, I have a question about measles. I recently learned if you survive measles, your immune memory is wiped out. It's called immune amnesia. I've shared this little factoid with several of my friends, and no one has heard about it. I just got to tell you, Lisa, that in Immune 26, that was many years ago, 2019, we talked with Michael Minna about immune amnesia. So why don't you know about it? I suppose this means if you survive measles, all the diseases you've acquired immunity to are now a threat. Does being vaccinated against measles as a child protect you from immune amnesia as an adult, or should adults get vaccinated again? If immunity amnesia is a real possibility, parents who are on the fence about vaccinating their kids should know about it. It's so sad. I'm so sad that the current times make these worries salient. Love the show. You both are doing great. Okay.
All right, so let's go through. So maybe you're not hanging out with enough science nerds, Lisa. But if you listen to the whole plethora of TWiCs, Immune's one of my favorite shows, Vincent, by the way.
It's nice.
Much as I like the deep dive TWiV and all the rest, my heart, right? My PhD was in immunology. So I love the those shows. And this is a huge issue. And so again, I guess it's an audience. I was joking to people before the Super Bowl about, I don't know how the Eagles are going to do. I hear a lot of them are sick. It was a bird flu joke and no one got it until I told it to my ID colleagues and they busted out laughing, right? Okay. So you got to, if you hang out with the right crowd, immunity amnesia, it's a thing. I wonder who that crowd actually is. But yeah, this is not only as we've talked about, we're seeing about 40% of these kids currently who get measles ending up in the hospital. We're seeing, what's the mortality, 1 in 1,000? So back in the days of 500,000 cases a year, you saw 500 children dying. But not only that, this immunity amnesia where, yes, as you point out, it wipes out this memory. And so, listen to Immune 26. They really cover this in detail. But yeah, this is a problem, not just everything related to measles, but also the fact that it's going to wipe out all that hard-earned memory that you've developed over time.
Now, of course, you can restore the memory by getting vaccinated or infected, but it may be hard to do that, right?
I'm just thinking all these folks with relying on their COVID survivor immunity, and now boom, they get measles.
Yep. Get measles, it's all out the door. Matthew writes, can you explain why 2 annual COVID vaccines are recommended for high-risk groups, but just 1 flu shot? I would think that both would enhance short-term antibodies and would be helpful if taken twice a year.
I'd love to have a dialogue with Paul Offit about this one, right? So it's really interesting. So, we always want to have evidence-based recommendations for things, right? And so the flu shot, we've talked about this. It used to be a lot of docs would try to get their patients to get their flu shots August, September. Part of it may have been a business model. You get all your physical exams in during August and September, and the hook is, hey, if you don't come in for your physical, you're not going to get your flu shot. It probably was too early. Well, no, it was too early. No, forget about probably. The advice is you really want to be getting your flu shots end of October, early November, because timing matters with flu shots. You're going to lose about 10 or 15% of whatever protection you're going to get per month, right? So now we sort of have this issue where a lot of folks maybe got their vaccine in early October, and now November, December, January, February, about 4 months in. So, would it make sense to get that second flu shot? The problem is we really haven't studied it. We're not really sure. It makes sense. And again, we sort of made the recommendations for the 2 COVID shots with kind of the same, saying it sort of makes sense before we actually really did that study that I just suggested we should do. So that's the context.
And Kristen writes, my husband and oldest kid are sick with COVID. It stinks, but since they've each had vaccines, including one in the fall, they'll be okay. However, this bout has really taken my husband out. So far, he's been sick for 4 full days. He started Paxlovid the same day he woke up feeling terrible and tested positive. He went back to the doctor today for a chest x-ray. The cough is nonstop. The x-ray was clear, and the doctor told him that since he received his COVID vaccine in November, the Paxlovid wasn't doing anything, and he's just experiencing a normal course of COVID. I just wanted to hear your thoughts on this. Is this true?
All right, Kristen. So this is a good one, and we'll go through it in detail because this is really important. People want to take their medicine and then feel better, right? They want to I started the Paxlovid. The next day I felt great. And we talked about, the art of medicine, right? Where the pharmaceutical companies made the Z-Pak 5 days when you could really probably just take a gram on the first day and 500 the next day and be done. It's in your system for 2 weeks. But they did this sort of timing idea where they realized you'd be sick for a day or two, and then you see the doctor and you take your 5 days of this antibiotic that does nothing for your virus, and then you feel better right about the time that you finish. And so you get this hey, that stuff really worked. Unfortunately, what is the data on Paxlovid? Paxlovid, we just talked about the Shinogi study on emcitrelvir. It doesn't really make you feel better quicker. But what it does in high-risk individuals, evidence-based, multiple studies, hundreds of studies now, vaccinated, unvaccinated, et cetera, it's going to reduce the severity of that second week. It's going to reduce your risk of being in the hospital. It's going to reduce your risk of dying. So you did the right thing here. I just don't understand, this suggestion that Paxlovid isn't doing anything.
So when I got Paxlovid a while ago, I had already been vaccinated, and I started the day I tested positive, and the next day my symptoms were alleviated substantially.
That's excellent.
And they stayed gone, and there wasn't a 2-week thing. So, I think it depends on the patient. Right?
Yeah.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Thank you. And everyone, be safe.